Hazlewood. I'm Linda Wilhelm with the Canadian Arthritis Patient Alliance, and thank you for coming to our booth today to answer a couple of questions. Can you provide our audience with just a short introduction about yourself and what you do?
Yeah, so my name is Glen Hazlewood. I'm a rheumatologist practicing in Calgary, Alberta, and I'm also I do a lot of research, and I'm finishing off my PhD. And my PhD is looking at treatment choices in patients with early rheumatoid arthritis and how people make treatment decisions and how they weigh the risks and benefits of treatment, and then how we can use that to make better, more patient-centered treatment recommendations.
Amazing. That was very, very important. From somebody who's had it for a long time, I sure would have liked to have had some more of that done when I was first diagnosed 30 years ago. What do you think is the most exciting and important thing that's coming out of this year's Canadian Rheumatology Association annual meeting?
I think it's hard to pick one thing, but I think the discussion around pre-rheumatoid arthritis for me was the most interesting thing. Obviously, the amazing talk by Dr. Balawi, who's done a lot of, pioneered a lot of the research in it. I think to me that was kind of, it's kind of made its way through different themes throughout the meeting. So.
Yeah, it's really exciting, and to know that maybe in the future there's a time we'll actually be able to diagnose it before people have it, and so people don't even have to get it anymore.
Exactly,
prevention.
Yeah.
Incredible. What do you think about the use of social media in relation to patient care and research?
I think it's fantastic. I think anything that disseminates research, so gets the research out to patients, and anything that engages patients in terms of being interested in, in their own health, and then potentially interested in being engaged with researchers or with clinicians at a more general level. So I think it's fantastic, anything that promotes that.
Yeah, and when we think about this younger generation coming up and how they receive information compared to an old timer like me, which I'm on social media. I get a lot of information out of Facebook, and CAPA has a Facebook page, as do all the arthritis consumer organizations, and we get a lot of great feedback from the patient community on what we post, and people find that information very valuable. But I think even with this next generation coming up, they're completely different on how they receive information.
Yeah.
So it's going to be really critical in reaching them.
Absolutely.
You did a presentation called Treatment Preferences of Patients with Early Rheumatoid Arthritis, a Discrete Choice Experiment. Can you tell us what early rheumatoid arthritis is, and how do you determine if somebody has early RA?
Yeah, so that's a matter of debate, I would say. I think the target keeps moving earlier and earlier. The reason we looked at patients with early RA, and we used a 2-year cutoff, so we defined anybody who had been diagnosed with rheumatoid arthritis within 2 years. We did that because we were interested in sort of looking at people who've been recently diagnosed with the condition and their preferences at that time. But certainly early, we're now even we've heard from multiple talks is looking at even before RA. And really, I think rheumatoid arthritis is thought of now as more of a continuum of disease as opposed to a specific cutoff. So people can, exactly. People can start with, maybe just some mild symptoms and be sort of in an unclassified or undifferentiated state, and then over time progress into rheumatoid arthritis. So the target's moving, but we used a 2-year time frame.
And I look back when I first was diagnosed. I was diagnosed in 1983, and the difference in treatment then compared to now.
Yes.
But even the difference in me as a patient then and now, where when you talk about adherence and about learning about what the disease is, and what I was as a patient then, I was scared. I was kind of in denial. I was a young woman, couldn't have arthritis. That's what old people get, and that kind of thing. So it's very different than somebody who's had disease for a long time, who knows. So if you don't do these things, then you're going to be in a significant amount of pain, and you're going to cause a lot of joint destruction, and it's really going to severely affect your life. So I think it's fascinating about to have the early. So what is discrete choice experiment?
So discrete choice experiment is a fancy term for a type of survey. And what it is it's a survey where you give people different choices. So we ask people to choose either treatment A or treatment B, and the treatments are a little bit different. And so it came from sort of marketing research in terms of, if we're trying to, develop a new computer, how do we, what's the best combination of features of that computer that people want? Mm-hmm. So it's been adapted now into healthcare and looking at treatment choices. Okay. So the idea is if you give people treatment choices where the benefits might be better with one treatment, but it may have a certain side effect. Okay. Or another treatment might be better, but you have to take it by injection versus pills. Okay. And we ask people to make a number of these choices, and then from their responses, we can determine what was kind of driving their decisions.
So maybe they'd be more apt to follow through and take their medications as prescribed.
Yeah, well, that's the idea. If you can engage people, that maybe they'll be more. If people are on treatments that are sort of consistent with their internal values of what they want, the idea is that you can engage them more in the treatment process and perhaps have better adherence and better outcomes.
So how can one treat early RA?
So there's a lot of different options. I think if you look at the kind of standard treatment, it would be methotrexate for early RA for majority of patients. The reason is we have good long-term data on methotrexate. It works very well, tends to be well tolerated over a long period of time. So that's really, we call that sort of the anchor drug or the main drug of treating early rheumatoid arthritis. And then beyond that, there's lots of other different options. So you can give it with other medications. You can use methotrexate either by pills or by injection, and there's pros and cons to that argument. And then there's the new biologic medications, which we use. We tend to reserve if people aren't having a good response to the traditional medications that we've had around for a long time.
And what can you do to prevent early RA?
So that's a very good question. The risk factors we know that are associated with developing RA. So we're talking about people who don't have RA yet, but maybe at high risk. So smoking. So stopping smoking is the one thing we recommend as a modifiable risk factor. Some of it's genetic, which you can't obviously modify. And then gingivitis or periodontitis or gum disease has been associated with. Whether treating that can prevent rheumatoid arthritis is less clear, but those are the modifiable risk factors we know of. We're not at the stage yet where we're looking at sort of drug therapy for people to prevent rheumatoid arthritis, but that was a big debate at the CRA meeting this year, and something that may be coming in the pipeline.
Are there any other highlights that you could share with our audience?
I think the highlight for me of this meeting is just seeing what excellent research that Canadian rheumatologists and Canadian trainees are doing. So, without signaling out one presentation, I think the highlight is just seeing sort of the diversity and the wealth of information and the engagement with the AHPA, with the allied health, with patient groups. Is just so. I think it's my favorite thing to come to every year.
Unlike 1983, when I was told to take the big bottles of Entropin, and then if I took too many till my ears started to ring, that meant I was taking too many, and I had to back off, and then there was a step up, and so glad to see how far we've come in 30 years. It's gratifying. I haven't benefited completely from all the wonderful things that happened, but certainly enough that I've thank you for what you do.
Thank you. Yeah, thank you for having me.